Good afternoon. Welcome to today's webinar, Ferns, Medico-Legal Considerations. During this webinar, our presenter will cover essential concepts in understanding burn injuries and their sequelae, classifications, types, mechanisms, and treatment modalities will be clearly discussed to familiarize the participants with the current thoughts in this field. Medico-legal considerations pertinent to plaintiff and defense aspects of burn injury litigation will be discussed with a number of case examples. The presenter for today's webinar is Dr. Michel Brones. Dr. Brones is a board-certified plastic and reconstructive surgeon. He is currently in private practice after 17 years of experience as a plastic and reconstructive burn surgeon at the Grossman Burn Center in Sherman Oaks Hospital in Sherman Oaks, California. Dr. Brones specializes in all areas of plastic and reconstructive surgery, with special emphasis on burn injuries, hand surgery, cosmetic, and reconstructive procedures. Dr. Brones has more than 25 years of experience testifying for plaintiff and defense cases involving personal injury, product liability, medical malpractice, and civil and criminal cases.
Start first with total body surface area burn, the rule of nines, the burn unit admission guidelines, and the fluid resuscitation guidelines. I'm sure that if you've seen any significant burn injury in your practice, you often come across with this total body surface area burn. What it means is what percentage of the body has been affected by the injury, and certainly this has great implications because the greater the area of the burn, of course, the greater the mortality and or morbidity of the injury. In order to assess the total body surface area, we use a diagram, or quickly we use the rule of nines that I'm going to show you in another diagram. Also, I wanted to talk about some of the burn unit admission guidelines, because this is one of the medico-legal areas in which some cases are seen as to when a case was or was not properly sent to a burn unit. And finally, we'll talk a little bit about the fluid resuscitation guidelines. Again, some of the cases of malpractice involving whether or not the patient was appropriately treated by the referring facility, and in some cases whether or not the patient was appropriately treated by the receiving burn unit. So all of these elements are important elements because they can be a source of malpractice action. So let's go a little bit into the area of burn and talk about what are the guidelines for a burn center referral. And as you can see there, hopefully it is clear in your computers what I was referring as the rule of nines. Each upper extremity is considered 9%. As you can see there, it's 4.5% for the arm, but that is for the front and back, 4.5, so it will be equivalent to 9. Likewise, the lower extremities, the entire lower extremity is about 18%, 9% for the front and 9% for the back. As you can see, the chest and abdomen is about 18%, the back is about 18%, and the face, the head actually, is 4.5 for the face, 4.5 for the back of the head, so it's a total of 9% for the head, and 1% for the genitalia in order to complete the 100%. This becomes very important when you talk about, you combine the percentage of the burn with, of course, the depth of the burn. It is not the same to have, let's say, a 50% burn that is only first and superficial second degree burn, and we'll talk about those type of burns a little bit later on, than to have a 30% burn that is a third-degree burn or even a fourth-degree burn. In considerations of burns, we take in consideration the depth of the burn and, of course, the extent of the burn. Now, what represents, according to the American Burn Association, an indication for burn center management? And this becomes an issue when some institutions either do not refer or do not allow the patient to be sent to a burn center, or when there is a delay in referral to a burn center. So let's look at the guide. Any partial thickness burns, and a partial thickness burn is a second-degree burn that is more than 10% total body surface area burn, would be an indication for burn center admission. Now, this area is a little bit gray as to whether the patient has to go to a burn center, but certainly the patient could go. Any burns that, besides that, involve the face, the hands, the feet, the genitalia, perineum, or major joint areas are better evaluated in a burn center. Third-degree burns, electrical injuries, including lightning, chemical injuries, inhalation injuries, and circumferential limb or chest burns are better evaluated in a burn center setting. The reason for that is because, of course, the burn center is equipped with the appropriate modalities of treatment, with the appropriate diagnosis of treatment, and with the nursing personnel that would take care of these issues.